This is the Neurosurgery Podcast. Welcome back to the Neurosurgery Podcast. Today we are delighted to be joined again by our dear friend Anthony DiGiorgio, a trauma neurosurgeon at the University of California, San Francisco. But first, before we dive into the topic of today's discussion, I want to take just a quick moment to say a massive thank you to the AANS and the European counterpart, the EANS, who just hosted me for a week in Sofia, Bulgaria, with an exchange program where they bring some American trainees to their educational courses for the European residents. I was so honored to go for a week-long course on spine neurosurgery with a host of European experts and learn not just what they do differently in Europe, but actually very, very many similarities in practice between us and our friends across the pond. So I say this for the listeners, one, to bring your attention to this course for any trainees in the States. Please apply. There's only a limited number of spots, but apply for this. It's a phenomenal experience. But also to tell our listeners, of course, I cornered some of the experts in Europe and asked them to come on the show. So look forward in the coming weeks to hearing from some European experts in spine and general neurosurgery. And anyone listening in Europe, if you think that one of your professors or one of your partners or you yourself would be a great representative to come on the show and tell Americans what we do wrong, please write to us at neurosurgerypodcast@gmail.com. Message us on Twitter, NSGY Podcast on Twitter. Obviously, this was a spine course, so most of the people I talked to were spine neurosurgeons, but we'd love to hear from anyone, anywhere in Europe to tell us what we're doing wrong and maybe a little bit about what we're doing right. But it was a great experience. I met so many phenomenal other trainees. Let me tell you, neurosurgeons are the same anywhere in the world. But with that, let's bring things back home and re-welcome our friend, Dr. DiGiorgio. In case anyone listening has missed your previous appearances on the show, please take a moment and say hello.
Thanks, JP, and thanks, Dr. Wang. It's a pleasure to be back. I am a neurosurgeon, as you mentioned, at University of California, San Francisco, and a lot of my work focuses on trauma, traumatic brain injury, traumatic spinal cord injury, but also socioeconomics and healthcare policy, where I have some grants to study access to care issues and enjoy arguing on X with people about how we can fix the American healthcare system.
Yes, and I applaud your humility. You also have a podcast of your own, The Doctor's Lounge, which we've talked about on this show before. You and I have a Substack together of the same name, The Doctor's Lounge. We'll link to all this. Plugs. Anytime anyone wants to learn about how healthcare, and in particular neurosurgery, actually works at a system level, Anthony DiGiorgio is the man to go see. So with that, let's dive into a major issue affecting neurosurgeons here stateside, which is workforce issues. I shared on X recently a wonderful article from Mike Lawton and his colleagues looking at projected workforce changes in the coming decade for American neurosurgeons. And it blew up a little bit. So it seems like a timely discussion to have today. And so why don't we set the stage first for any of our younger listeners or people just so busy in practice that they don't have time to look and think and worry about the workforce issues facing us in the decades to come. How are things looking for us keeping our supply of neurosurgeons at a healthy level?
Well, it all depends what you mean by a healthy level. So these papers, there was two. There was the Lawton paper, and there was also a similar one in JNS that came out. And they both looked at similar issues. They used the Harissa's health force work simulation model, and they basically took the current level of neurosurgeons as a baseline adequate and just modeled what the population change is going to do and what the workforce will do. And of course, we are not increasing our workforce at the same rate that population is growing, especially with the so-called silver tsunami of elderly patients who are going to need our services. So they're predicting a shortage just simply based on overall FTEs in areas. It's a rather crude way to look at it, but it is. It does show that there's simply not enough neurosurgeons to go around. I tend to think that there's more policy things we can do to alleviate this. There's no magic switch we can flip to increase our training pipeline. And this is something, JP, you and I have talked about extensively. you need an adequate breadth and depth of cases to train a competent neurosurgeon. And frankly, I think there's maybe a little room at the margins, but you're not going to magically increase the neurosurgical trainees by 50% and maintain the same quality. So I really don't think that we can fix this workforce issue by increasing the training pipeline. We have to find ways to empower neurosurgeons to be more efficient, to work at the top of their license more. And I really think a lot of it is going to come down to ownership and giving physicians more control over the ownership of healthcare, over things like surgery centers, and making it so that we can actually be a lot more productive than we currently are.
You know, that's such a great message. I think we were commenting a couple weeks ago on this podcast. Our trainees here, the ones that are senior level fellows, chief residents, senior residents, they almost worry there are too many trainees. I think it may be a consequence more of like the job market, what type of jobs are available, as you've indicated in the past on our podcast, and maybe the concentration in coastal cities, right? Like there are all these factors. But, Anthony, I think it's very interesting, these two papers. I don't feel like they adequately account for, at least statistically, maybe in the editorial part, about the future of neurosurgery. Like Elon Musk says that we're going to need another 2,000 neurosurgeons just to put in Neuralinks, or 2,000 robots, maybe. I don't know. Can you just sort of segue a little comment on, like, do you think the data in these papers are reflective of the future, or do you think they're simply frozen into like 1999 type analyses?
Yeah. Again, they use the current sort of distribution of neurosurgeons as the baseline, and they didn't really bake those assumptions in. You could say, on one hand, maybe we'll need fewer neurosurgeons. I think some things will move out of the neurosurgery realm. They're taking out chronic subdural hematomas endovascularly now, right? And so if that takes off, there's certain things that are going to move out of the neurosurgeon's hands. But on the other hand, as we get better brain-machine interface, you might need more neurosurgeons for that. And then, of course, the big X factor is, how will technology affect us in the future? Are we going to all be replaced by robots? I don't think so, at least not in the near term. And I think AI can actually be a really empowering tool. Again, getting it so neurosurgeons can be more efficient and work more at the top of our license. I think AI can really empower neurosurgeons to do better and do more with less.
Yeah, so I think this problem does kind of focus on the two ends of a neurosurgeon's career. The beginning, where people want to make more neurosurgeons now, and the end, where the other way to keep your workforce high numbered is by people not retiring. And I think right now, talking about being efficient and operating at the top of your license, I want to talk about that retention problem for getting people to stay in the workforce productively, rather than retiring. And then maybe we can return to some of the questions of training and producing more neurosurgeons later in the conversation. So you talk about AI making us so efficient, operating at the top of our license. The other side of that coin is making sure that we're happy, that people are satisfied, that they enjoy their job. I'm not going to say the dirty words work-life balance, Dr. Wang. I know you hate it, but not so much about the degree to which you operate effectively and maximize the hours each day, but how many of your days and how many of your years of life are you willing to give to the career, to the profession, to the patients in your country? And a lot of things we often talk about are that kind of satisfaction question. And so maybe, Anthony, talk a bit about how neurosurgeons in this country and the policies defining the systems in which those neurosurgeons operate can be changed to not only maximize efficiency, but perhaps through that efficiency, maximize our sense of pleasure, satisfaction, ownership in the work that we do every day. And maybe, just maybe, somebody might work 1 year longer than they would have otherwise.
Yeah, those are great points. And, I think the dirty word is burnout, and like you said, work-life balance. But it is true that a lot of physicians, not just neurosurgeons, are looking for the quickest exit, right? Because they've become employees. They don't have real ownership stake in the healthcare delivery. And so once they reach financial security, or get sick of being a W-2 employee and being bossed around by people with no medical background, they look for an early exit. And for a lot of neurosurgeons, that means going into locums. I've talked to quite a few neurosurgeons who drop their practice and just do locums, which they enjoy because they don't have to deal with a lot of the bureaucracy. They get to just cover a hospital for a weekend and then take the rest of the week off. Is a way to maintain a little financial independence. And that's part of the problem. Dr. Wang, you mentioned that there's a lot of saturation in coastal cities, and you need a lot of workforce in rural areas, and that's really being covered by locums. But if you look at the flip side, what would happen if physicians could own facilities, invest in their communities? You might get some surgeon who's from a rural area who goes there, opens up a hospital, can own an imaging center, can own the physical therapy. They're establishing roots in that community. And that ownership means not only do they control what their lifestyle is like, they don't have to listen to a bunch of bureaucrats to provide care, and they've established something. They're going to probably invest a lot of time and work longer in that community if they can do that. Right now, we prohibit that from happening, right? Stark law says that makes it incredibly difficult to own your own imaging center and your own PT. The physician-owned hospital ban means you can't own a hospital. But if you had somebody that did that, I spoke to somebody who owns his own imaging center, PT, and surgery center. He says he gets somebody in who has, a new drop foot or progressing cervical myelopathy. He can get him an MRI the same day. He can get him in to get an injection the next day. And if it requires surgery, he can get him in the next week. Right. And so allowing physicians to own gives us the opportunity to build that infrastructure, makes us work more efficiently, means more patients can be seen. And somebody who has that investment in their local community is simply going to practice longer and give back more to the community instead of being somebody who's just a W-2 employee of, large hospital system X.
I want to come back to something you touched on, Anthony, which is this concept of the friction points for the individual surgeon. Right? We hear a lot about burnout, but it's always in this sort of generalistic sense, like doctors, right, as a general group. Can you just tell me, because everybody's very aware of their own personal problems, but sometimes it's nice to have a little bit of Schadenfreude to understand other people are suffering too. Can you give me like a top 3 or top 5 of what you in your time as a neurosurgical leader in academia, CSNS level for attendings? We're not talking about residents right now. Attendings, what is it that really gets in their crawl? Like, what is it actually? Because I suspect it's a little bit different from the typical worker or doctor even.
Yeah, I think it's on both sides. One, it's obviously utilization management, having to beg insurance companies or third party payers to be able to do the procedures and surgeries that need to be done. Right? If somebody's paying out of pocket, getting in the MRI that day is easy because they're just paying out of pocket. But if you have to ask permission from an insurance company to get the MRI, that is a big sort of source of friction and frustration. And then on the hospital side, right? If you want to get an MRI done, I don't know how much pull you have at your hospital, but I know a lot of neurosurgeons, if they want to get an MRI done urgently and not go through the ER, right, that takes a bunch of phone calls. You got to beg the radiology department to find you a slot and slip somebody in to get that MRI done. And then heaven forbid you need to add on a urgent surgery. You're either again going through the ER and getting put on the add-on list and having to wait until the weekend or late at night, or begging the OR front desk to shift some cases around and get a case in, right? So there's all these different friction points when you're like, patient needs X. I know what patient needs, and I just can't get there without 50 different phone calls and begging 60 different administrators to get the things done that I know need to get done. And again, if you own the whole facility, if patients are paying out of an HSA or if there's minimal third-party payment, all that friction goes away.
Yeah, so I think that we often talk about these dissatisfactions or these friction points, these frustrations, and it seems intuitive that as these aspects of modern medical practice in the States increase, then burnout and dissatisfaction will also increase. And so people will retire sooner, and then we'll have a shortage of physicians, including neurosurgeons. But I wonder if, and if you don't know this offhand, I don't want to put you on the spot, but I wonder if the trends that we see with where there are actually shortages of neurosurgeons in particular and other physicians track with places that have more of these frictions. And I know that a lot of the classically cited differences are obviously the rural populations have physician shortages and the big cities have plenty of doctors because that's where people want to live. But the big cities also have the large ivory tower academic institutions where physicians tend to be employed and have some of these frustrations. So do you, even anecdotally, just from your friends and the people who share their frustrations with you and me online, do you notice any difference in job satisfaction between people who are employed and have these issues and people who are maybe in the community and can get things done more quickly if they have some ownership? And have you actually seen any difference in trends in retirement rate or retirement age between these groups?
There's no data on that, but it's somebody that you should probably have on the show is Carlos Cardenas, who is one of the owners of Doctors Hospital Renaissance in McAllen, Texas. Right, so this is a level 1 trauma center in rural Texas that is owned by physicians. It was grandfathered in prior to the ACA ban. That treats their community. They have neurosurgeons there. They have, I think, internal medicine residency. They have OB. They do something like 80% Medicaid deliveries for OB, and they deliver several thousand patients a year. And they're able to make this hospital work. And the doctors that work there, they have ownership stake and they love it, right? They're from the community. They're giving back to their community. And so you have a rural hospital, a rural area that has this amazing facility that is treating patients, not just private pay patients, but Medicaid patients. And everyone there is happy, and it's extremely high value care. And the doctors there can just get the care done because, again, they own the facility. They don't have to deal with all these administrators. So no, there's no data on retirement, but I guarantee if you lined up those doctors versus some other doctors that are employed at a large hospital system, the satisfaction scores are going to be substantially different.
Yeah, shout out to Dr. Cardenas. I love that you wove that history into it. I think people forget this, that during the Affordable Care Act, otherwise known as Obamacare, physicians, at least surgeons, lost out big on this piece of it, which was suddenly we're the bad guys. Like the only
Right.
reason a doctor would own a hospital is because they're greedy, right? And here you're indicating they're doing a lot of charity care, they're community based. Like physicians may be bad at managing, but we can argue that we probably have a better true north than the typical administrator, right? Yeah.
Oh, absolutely.
So, I'd like to pimp a lot, and I know it's not in vogue to pimp anymore, but I like to pimp because I feel like when people are asked a question under pressure, the amygdala fires, so then it fires the hippocampus and actually might remember or go look up the answer or might remember the actual answer. And so ironically, this week was asking the fellows and residents, I'm like, so you guys know how many spine surgeons there are in America, right? And I got this weird, when they look around the microscope, they're like operating their microscope, they look around the microscope like clue. And I'm like, you guys don't know how many neurosurgeons there are? I mean, it's harder to know spine surgeons, but like how many neurosurgeons in America? Like you take whatever tranche you want, board certified, not certified, in training. They couldn't come up with, I said, give me to like within one power. Is it 50 or is it 5 million? Like, give me some kind of number that makes me think that you have like firing neurons. And I don't want to call these guys out because they're very smart. And nobody in the room could answer. Maybe they're too terrified then. They couldn't even answer. So, and we know that we don't really know the exact number for a lot of funny reasons. You can please highlight why that might be, but also tell us what you think, like tell us the number or the range, and then tell us what you think may be the right number. And I know that this is just a prediction, right? Like you don't really know until you change the system, but I think that's something that people would want to kind of have an idea of.
Yeah, so it's about, if I'm not wrong, about 6,000 neurosurgeons, and I think the total spine surgeons probably around 20,000. It's about 1 million doctors in the U.S. We don't know what the right number is, and that's largely an economic question. We don't know the right number of lawyers or restaurants. Right. The way that we know if an area has the right number of certain things is we respond to price signals. Right. And so if there's one neurosurgeon in a town of 1 million people and that surgeon was allowed to charge whatever they wanted, that would signal to people what the relative supply and demand is of that surgeon's services. And so if he was charging $1,000 per clinic visit, that would show that there's a high demand. And that would tell you that there's room for another neurosurgeon to move in and maybe charge $700 for a clinic visit. And that price signal would help alleviate that shortage. Without price signals, we can't actually tell what the right number of neurosurgeons is. We can do things like ask, well, what is the wait time? But wait time can be manipulated. And how do you really track that? And are people going through the ER to get care instead of, coming through the clinic? So there's no real true north to what is the right number of neurosurgeons. And I would, push back at anyone who says that what we have now is the baseline, right number of neurosurgeons or that there is some magic number. I think until you can really assess using some sort of method to allocate resources, you're not going to know. And the only real way we can, for any economic question to know how to allocate resources is with price signals. And we've completely obscured that signal with the way we pay physicians.
I love that you bring the economist bent to that because the typical answer does not come from economics. It comes from either policy or public health, or like there's another bent on it, right? Some
Right.
kind of policy driver. And I would say that what you just said, that little soundbite of like a minute and a half, should be listened to by every trainee's significant other, because absent that price signal, it's like, oh well, obviously Paris in the summer, right? Like that's the only consideration. And then people don't realize, like, I think we have a new surgeon in South Florida, like maybe every 3 weeks now, and it's obvious why. Like there's a lot of good reasons to be here, but they're not responding to market signal. Maybe they don't have to, maybe they shouldn't, but I do think that that approach or idea behind it, the philosophy behind it, is something that's completely lost, and maybe one of the reasons why there's frustration in healthcare, like at a core level, right?
Yeah, I totally agree. And there are some price signals, right? Like if there's one hospital and they're desperate for weekend coverage for a neurosurgeon, or they're going to lose their level 1 status, then they're going to pay a lot, for locums coverage. But that makes the neurosurgeon dependent on a hospital subsidy, when we should really have the neurosurgeon driving the utilization themselves, right? You should be able to go hang up a shingle and know what the prices are in that locality, rather than be dependent on a hospital subsidy for your income.
Yeah, by chance and happenstance, like all great things in life, we were talking about the number of neurosurgeons per capita with some of my friends at a bar one night at this course in Europe, and we came up between the GPTs and the Googles with around 5,000 neurosurgeons in America out of 50,000 worldwide. So we've got a tenth of neurosurgeons in the world just here in the States. And a fun fact: the nation we found that had the highest density of neurosurgeons per population was Japan,
Hmm.
but apparently some of these people counted in that number of neurosurgeons, their practice is exclusively radiation oncology or things like that, not open procedures, because there's no way a population of that size could support 7,000 people doing full open operative neurosurgery, unless, Dr. Wang, you think I'm wrong.
No, you're right. And the Japan question is so interesting, and they never talk about it. They have double the number of neurosurgeons, about less than half the population. And the funny thing about Japan is, and you can correct me if I'm wrong, Anthony, all doctors are paid the same. In other words, if you're a pediatrician working 20 hours a week, if you're a neurosurgeon working 80, they're paid the same. Now, paid is a lot of different things, but like the general sense is like you're paid by a hospital. Everybody's paid the same. Yet people still go into neurosurgery and they're doing a ton of research, writing lots of papers. Japan has always fascinated me. It just shows how much of an attraction there is to this specialty that we were so
And
lucky to be in.
and further, before you comment on this, Anthony, I heard this from people from many different European nations. One in particular, hey, Leon, if you're listening, a new friend of mine who told me he actually listens to the show. He's a trainee in Germany, and he was explaining to me that in the German system, residency is just as hard. It's brutal. It's difficult, and they take pride in it. And there is the prestige, but it's not very difficult to get in. And many people from many different countries in Europe told me that getting into neurosurgical residency and training was not very difficult and as competitive, even if the training was just as rigorous and just as brutal, and the pay wasn't as great, compared to how competitive just the process is to get a training spot here in America, which is quite competitive. And so maybe this could be a perfect pivot to talk about that other end of the workforce issue, which is making more neurosurgeons to replenish the stock as people retire. Anthony, what problems do we have, or perhaps not problems, but finite limitations from the laws of physics and economics, do we have at generating new neurosurgeons with just the wave of a magic wand?
Yeah, I mean, you have to, again, as we mentioned, have the sufficient breadth and depth of cases to have a competent neurosurgeon trained. And I think we've mostly probably maxed out. I'm sure there's some hospitals and programs that could add a neurosurgeon here or there, but you're talking about maybe 5 to 10% increase at best, and then you have to wait 7 years for those residents to get trained and released into the wild. Meanwhile, you're losing neurosurgeons at a pretty alarming rate. Um, and I just don't think that there's much room to increase that. If you could create more medical schools, but again, you're sort of the bottleneck on the pipeline is with residency. I think the international comparisons are interesting, and this is some of the debates we've had. In U.S., we are often criticized for surgeons working overnight and then having to work a full day the next day. I'm on call right now. I'm in my scrubs. I was up most of last night answering phone calls, and I'm still on call today. And if something comes in, I'll have to go in and do it. And I'm happy to do that. And I think we've all operated tired, and we're good at it because we did that through residency, right? I know how to triage things when I'm dead tired, and I can operate and I can do a craniotomy basically in my sleep because I've done it so many times in the middle of the night. And that's really what you need for a competent neurosurgeon. I don't want some neurosurgeon going out into the community and taking overnight call for the first time as an attending, operating in the middle of the night, tired as the first time as an attending. They should be doing that multiple times during training. Internationally, you mentioned comparing to Japan or Germany. So we actually have more neurosurgeons per capita than some of the Anglosphere countries such as the UK and Australia. They have fewer neurosurgeons per capita, but when they train their neurosurgeons, they have very strict, even more strict work hour rules than we have. And so I question, how well trained are those neurosurgeons when they get out and are taking call, and how do those countries work with overnight call and making sure that there's enough neurosurgeons to go around, attending neurosurgeons to cover overnight call and still be able to do elective cases the next day. So I don't know. I don't know what the right number is, but the training pipeline is probably not going to be increased that much anytime soon.
Yeah. Well, let me ask you this, because one of the and especially talking about international surgeons, one of the solutions that's often proposed to the shrinking American physician workforce is importing doctors from other countries,
Right.
whether bringing them in to finish off their training, or in some places now people are talking about bringing in IMGs and no repeat training in the United States, which has been the norm, and just letting them come and start working. And there's a lot of debating you can have about how transferable are the skills to practice medicine in a different culture, now in a new country, language barriers, cultural differences, and in terms of relating to your patients. Is that fair to the American population, where we have people that would like to be doctors and want to practice medicine here, and we're not doing a good service to the American medical students that would like to practice medicine in our country? But here's something I'm going to throw at you, because this just occurred to me now. We've never talked about this, and I don't know if anyone brings this up in the debates, but perhaps a different solution than importing doctors from overseas is to just give more autonomy to residents in the United States. So if you have a shortage, and when we say that there's a physician shortage in this country, it means a shortage in people out of training with full attending privileges, so you can have call coverage or whatever. So even, an attending on call for neurosurgery at a university in this country is not getting called all night. You are right now because you're covering a community hospital, but most attendings at university systems, or even in the community with PAs, they're not getting every page. They're not getting every phone call. There's a barrier between them, which is a resident or a highly skilled mid-level. So if we do really say we have a physician shortage and we need more neurosurgeons to cover these areas, what that really means is we need someone with privileges to be fully ultimately on call. Why not just give more autonomy to senior or chief residents, and then we have an immediate force multiplier? What do you think?
Well, correct me if I'm wrong, Dr. Wang, but back in the day, it used to be that a lot of county hospitals were staffed by PGY 6 and 7 residents that were essentially unsupervised. And again, it used to be that you could be a general practitioner, not neurosurgery, but just a general medical practitioner after just an intern year, right? You didn't need to complete a full residency to go out and practice. Ironically, California actually walked that back. You can no longer in California practice with just an intern year. However, they gave full practice autonomy to nurse practitioners. So I think a lot of people are trying to fill the gaps with non-physicians, nurse practitioners, or like you mentioned, in North Carolina, they made it so you don't need an American residency to practice medicine. So people are trying to fill those gaps, but I totally agree with you. Why aren't we looking at the current resident workforce and making sure that we're getting maximal value out of that instead of importing all these non-physicians to try to fill the gaps?
Yeah, actually, it probably would be a good idea to have one of the USC guys on, because USC's entire program changed. I mean, I don't know if you're feeling that in California, Anthony, but it drastically changed everything about the training, the way it's structured, the county hospital and the university hospital, right?
Yeah. And I think a lot of it was, people brought up the fact, well, why are you having these, the county hospital staffed by a chief resident? Don't these patients deserve the same level of care? And yeah, you can make that equity argument, but a lot of times it's like the point we keep bringing up, JP, the alternative to a rested neurosurgeon or to a tired neurosurgeon is not a rested neurosurgeon, it's no neurosurgeon, right? And so I think a lot of these places would rather have some sort of coverage, be it a chief resident, instead of having no coverage.
Yeah, it is interesting. I remember that when I was a resident, the idea was they never billed for services. So the idea was that the LA County hospital system was partially set up, although probably mostly, for migrant Mexican and then later Central American, Guatemalan, Honduran, Nicaraguan workers in the California industries, whether it be the garment district or the agricultural industry, right? So we knew very well. In fact, they had maps. They'd give it to someone in Mexico. They'd say, "Go to the county hospital, get your meningioma removed," and there was no problem with that. And this is not a
Right.
this is not a political statement of today's. This is a former. This is back in the old Republican California days, because those were the workers back then too. And so everybody remembers, like, when Bill Clinton got his haircut on the LAX tarmac, held up the entire air grid of America. He was getting his haircut. Air Force One was parked at LAX, and he was getting a haircut. They shut down LAX for like an hour, destroyed the whole air grid for the country, because of course it's interwoven. And the reason he was there was to come in to bail out, as they always did, with $5 billion from the federal government, the LA County system. And that was the way it worked. It was just old machine politics, I guess, right? So that's gone now. And now there's the anti-immigration people, right? And then there's the, oh, well, you've got to supervise residence people. And there's all these other, they are political forces coming to bear. As you guys have both said, the patients can't get the care anymore. So this is a really, really interesting thing. Nobody's talking about it in the way it really is existing, at least from the neurosurgical perspective, from my opinion. Like, nobody's talking about like the core issue, which is, yeah, there are people here who have no insurance or undocumented. How do they get a meningioma removed? Whatever your politics might be, right?
Right. Or even taking a step back, how do they get their primary care appointment? Why aren't we letting PGY2s and 3s run primary care clinics for a lot of these patients? Instead, we're going to give practice authority to nurse practitioners and PAs, but we're not giving it to American trained physicians who are in the midst of their training. So it to me, it doesn't make any sense.
Well, Anthony, partly because you're a great speaker, you're generous with your time, and you're so knowledgeable and ideological about what we do. You've been, I think, our most frequent guest, JP. Is that right?
He's got to be up there.
Oh gosh, you guys can do so much better than this.
But these are rookie numbers. We got to pump these numbers up.
Yeah, you or Luke Allen. So let's do this. Let you close in the way you would close your podcast, The Doctor's Lounge, right? Why don't you close this podcast the way you would close The Doctor's Lounge?
Well, Anish Koka usually hosts the Doctor's Lounge. So this is an unfair request. He is far more articulate at the hosting than I am. My plug would be to listen to the Doctor's Lounge. Everyone should tune in. We are live on X every Thursday at 6 p.m. Pacific time, 9 p.m. Eastern time. We have fantastic guests. Jay Bhattacharya will be coming up in the next few weeks, so please tune in. And Doctor's Lounge is available on Apple Podcasts and Spotify and X.